I want to just share, I've got some things to say about you, and then you can tell me whether they're all right or wrong, as a little bit of background, and then we'll dive into the rest of it. So as I said, we're fantastically privileged and grateful to have Ian with us tonight. He is, as I think you will all know, president of the ESGE currently. He is chairman at EMIC Medical Center in Israel, was educated, we were just hearing about his education in Minnesota, the gastroenterology fellowship from UCLA in the United States, and a master's in health services. His research interests include endoscopic diagnosis, gastrointestinal bleeding, capsular endoscopy, health economics, and their impact on quality of life. He currently holds the role of ESGE President, has worked, I think, on ESGE board before, and has been on multiple editorial boards of multiple journals, and has significant high-impact publications in many of the leading journals in gastroenterology as well as medicine. Ian, did I miss something, or is that
that was more than enough?
And so I would like to just talk about the structure of tonight. So we will start with a brief introduction, and that will be shortly. Then we'll go into some discussion about Professor Gralnek's role as the ESGE President. We'll bring in two seminal publications, which he has been instrumental in. One in basically one of the frameworks of how we treat gastrointestinal bleeding in 2024, and sedation for GI endoscopy procedures, and a position statement that came from ESGE recently. And then we'll delve into hopefully some of your questions, as well as a structured discussion with Professor Gralnek about these aspects. Why should we decide to do this webinar? Well, I think that a lot of our audience and a lot of you out there watching these webinars, potentially upper GI bleeding is something that on a scale of something to nothing, some people are very comfortable with, but a lot of people who are doing gastrointestinal bleeding in the night and on call are terrified of and need advice on. And so this is something which we hope to bring fully into frame today with one of the leading experts in the field.
So, yeah, I mean, at a certain level, I think when I was a counselor on the governing board and I decided to be on the executive committee, there's a point where you say, yes, I think I can contribute. I try and think strategically, and you really need to put the interests of the society ahead of your own maybe self-interest, or certainly ahead of your home country's interest, because you're representing 41 member societies from the Europe, North Africa, and the Middle East.
Yeah, so quite a long road, actually. It's
a long road. Yes, it's a long road. But again, if you enjoy doing this and you feel that you can actually, I think we do make an impact because we do turn out some very good quality documents that hopefully are taken up to a certain degree.
So I wanted to first start with the Glasgow-Blatchford Score, and I wanted to ask you, and to get the comment of the faculty, why this score? Why not another score? Because I think there are many. And for you, what were the important features of this score? And we show it here, the reason why you selected it for the document.
It was really, I mean, because there's probably the most evidence out there on this as a pre-endoscopy risk stratification score that's been validated in multiple places around the world in multiple populations. And this isn't anything new in 21. I mean, if you go back several years back, there are already recommendations for using the GBS to identify low-risk individuals. If you have a score of 0 or 1, you're considered so low risk, you can consider those individuals for early discharge from the emergency setting if you're able to perform an upper endoscopy, usually within the next couple of days. Now, has that translated into actual practice? I would say probably in most places it has not. Probably, and especially not in North America, probably because of the fear of litigation, because everybody thinks the one person they're going to discharge, then they're going to find in a pool of blood dead a couple of days later. But the evidence is there that those patients are very low risk. And like I said, there are others that are out there, but this has been shown to perform probably the best in terms of area under the curves, and its ability to identify the low risk as well as the high risk bleeders. But there are probably a couple studies that I would refer everybody to that have stood out. One was a large retrospective study by Stig Larsson from Denmark that basically looked at this, and it was very clear in the curves that he published that showed that if patients were scoped too early or too late, they had worse outcomes and actually higher mortality. And that was especially true in the sicker individuals with more comorbidities, so the ASA 3s and the ASA 4s. The sweet spot in that study was probably scoping individuals somewhere between 12 to 24 hours after they present. And that was one of the things we try to bring out in the guideline update, is that the clock in terms of timing should really start when they hit the door at the emergency department. Or I guess if it's in a hospitalized patient, you could start when they're first noticed they have the bleeding. But in-hospital bleeders are usually sicker. It's a different group, and I wouldn't equate those two groups. So this was more based on the ambulatory patients who are presenting.